from an emerge department perspective that we're going to be having access to CT heads and C-spine overnight. This is a first. I'll let Darcy talk about the specifics of the CT that's going to be done. And this will hopefully help with, one, patient care, two, speed of patient movement through the department, possibly some change in disposition overnight, which will help with some of the congestion from a patient flow perspective. At the very least, speed up availability of reports in the morning. So this is a huge step forward from our department perspective, and this has been a lot of hard work from Dave LaFlèche's perspective, and then Dr. Little and Dr. Boone have been working with the techs on indication from the X-ray tech perspective. That's who's actually carry this out for us. So Darcy's going to speak a little bit to the actual logistics and how it's going to roll out. And then Colin's going to speak to us a bit about actually just interpreting the CT heads and things that the emerge docs need to be aware of overnight to help with your initial assessment of the patient and management. So we'll let you just jump in there.
That's great. So I think what we really want to start with is not heads and C-spines, but just heads first of all. We may kind of go to C-spines gradually. Right now we don't have all our techs trained to do this, so in fact right now it's kind of like a pilot project. What I'll do is I'll be giving Aaron a schedule like this that has on it the days that techs are available to be doing this overnight and the ones that we currently don't have them trained up yet, but we're kind of in the process of doing that, okay? And I'll show you how that looks in a second. What the theory is that, if you need to have a CT head overnight, this would be kind of like something that's available where you can talk to the tech, you can get the CT done, it's just a plain CT head, and you can read it, you can look at it and get your first impression. If there are kind of major issues where you're not certain or where it's going to affect patient management, definitely feel free to call a radiologist, but that's not kind of like how we formalized it. We kind of formalized it in our head that this was kind of going to use it as a triage tool, and report it in the morning unless there are issues. And we're going to see how that works. I know they do this in other hospitals, and I know that it works well, so I think that it should work well. But again, this is kind of like a pilot project. So like all studies, we think we need to have a requisition. It starts off as only being non-contrast heads. We can only do it on those days where the CT trained person is in-house, and so we'll give you the schedule to do that. Not really, the theory is not to be calling in the CT tech from home initially, unless it's really clinically indicated that it needs to be done that night. Because the techs are, they have a certain level of comfort with the study, we want to have the patients, usually adults, probably not start off with children in this context. You can talk directly to the CT tech to order it, and I'll tell you how to contact them, and that again, like any other study, they're not supposed to give you any interpretation of the scan, although if they see something major, they're probably going to alert you, although you need to have a look at it. So the procedure is that, from midnight till 8 o'clock on those days where the CT tech who has some training is available, it's available. That the emerge doc will contact the tech directly, the tech will perform the CT scan and take the patient back, the technologist will inform the doctor that the study is done, the emerge doc will look at it, and hopefully, and I'm hoping this kind of acts as like an impetus that we use more and more, the eyesight preliminary box, so that more and more we get preliminaries in there, because I think that really helps us to know what you're thinking, so that if there's a discrepancy, we know how urgently to contact you. And I think in this context, in the head context, it's really probably important to know what was thought overnight. The radiologist is going to look at it first thing in the morning and dictate it. The technologist, if there's anything unforeseen, difficulties, etc., they can call the physician, the radiologist at home, they can call another technologist who has more experience, etc. And so what I wanted to do before we get to the nitty-gritty of looking at cases is just want to show you what the schedule looks like and what it's going to look like for you. So this is April. Well, okay, I'm going to show you what May looks like. I do have April, but it's not. Oh, it's a tab. Thank you. There it is. Okay, so this is kind of the yellow ones are days that we theoretically have a technologist who could do it, and the red ones we don't. So, but for those cases, those days that it's available, it's kind of like midnight till 8 o'clock. And the way to contact them is if you see them in the X-ray department, you can call 3618, or you can use Vocera X-ray tech. So those are kind of the ways to contact them. I have some text here. Should I ask, have I missed anything? Is there anything else that I should mention in terms of your kind of point of view? Melanie? No, we're so far so good? Okay, great. So now I'm going to give it to Colin to take over the actual kind of introduction to interpretation.
Okay, all right, so I happen to have a presentation, so I just thought, maybe I could just share all of you. CThead is a relatively simple CT study, but there's actually a lot to talk about. So I think our objective today in the next 40 minutes or so is not so much to go over everything that you may see on CThead, but to emphasize a few things. I would like to emphasize some practical tips that hopefully will increase our confidence in interpretation of CThead. So I'm going to show you some cases that may be a little bit more subtle or things that people don't always think about. I would emphasize important findings that have more immediate impact on patient care. Things that that you don't want to wait overnight. And I want to show some findings that are easy to overlook by anyone, including radiologists. And hopefully that will help us to improve our interpretation. And I'll go over a few directed pitfalls. So, in terms of general approach for image interpretation, obviously there's a standard algorithm of looking at CThead. You look at the Fourier-Wave differentiation, the vertical, you look for hemorrhage and things like that. But I just want to put it in a very simple way, just a very generic term. The head, the body is, we're lucky that the head is actually quite symmetric. So symmetry is a friend. And when you look at CThead, make sure that you look at great wavelength differentiation all around the head. You look for subtle things like effacement of basal sisters at the south side. These days, because of multi-detector CT, we have multi-planar with format. Take advantage of that, because sometimes you realize that there's something that is easy to pick up on the other plane. So for example, we used to look at axial plane, but sometimes you can pick up things on the other plane, or you can have to clarify things on the orthogonal planes. I'll show you some examples. Use the windowing and leveling properly, because sometimes some subtle findings is difficult to appreciate unless you window and level properly. And I'll show you examples of that. All studies are always radiologist express friends. So always pick up or compare with all studies, because the all studies will help you to pick up subtle new findings. So, this is I just want to show you why it's useful to look at other planes. If you look at this axial CThead, you realize that this patient at the foramen magnum is a bit crowded. If you look carefully, you pay attention, you realize that there's a bit too much. There's a bit of cerebral tonsillar atopia. You can pick it up on axial plane, but it's much easier to pick up when you look at the sagittal plane, because when you look at here, you can actually see that what you're seeing here is a crowding of the foramen magnum. You can quite easily appreciate that the cerebral tonsil is currently down below the foramen of magnum. Right? So it's just that the same finding you can appreciate better on the other plane, and this happens to be a congenital diarrheal bone malformation. Now this kind of patient can also have it obviously because they may alter CSF flow dynamics. Another example, this patient has a lacunar infra here. This one is, you can pick it up, but there's some that may be more subtle. But then we look at the other planes, you see that it's actually, it's much more discrete. It just just jumps out of the image. It's much easier to appreciate. And there are always findings like that. And the reason is that there's partial bottling on different planes, right? So if the lesion is very small, the density may not be as low as when you look at the other plane when you cut it a different way. The other thing is that sometimes you get partial volume. For example, if you look at this subtle infra at the cerebral cortex is very small. You're not sure whether you're looking at the cell side or you're looking at a real infarct. Look at the other plane. If it's a real infarct or real abnormality, the other plane will help you to confirm your findings. When you look at the CT head, remember, look at the great wavelength differentiation. Make sure that you go all the way around. You have to maintenance of the great wavelength differentiation all the way around the brain. Look at the cisterns. Look at the basal cisterns. Look at cerebral cell side, and see whether there's any asymmetry. If you have a tonsil, uncoiled herniation, the uncus of the temporal lobe will get pushed medially and inferiorly, and you will have asymmetry of this cistern, right? So that's how you pick up subtle mass effect. Same thing for foramen magnum. The cerebellar tonsils right here. If there's asymmetric mass effect, you see it being pushed and you face the foramen magnum. You can look at it on the axial plane. You can also look at it on the coronal plane. This is basically a plane that goes through this level, and you can see that the cistern here, if this herniation, the brain will push down medially and inferiorly. You will have a symmetric effacement of this basal cisterns right here. And same thing for the foramen magnum. Okay. All right. So this is just general approach, and I think it can be useful. Now, I just want to show you some real findings. I think one of the most common things that we encounter in ER situation is to roll hemorrhage. Now, I don't think anyone will have problem picking the abnormalities here, right? So we have the classic intracerebral hemorrhage right here. This is a hemorrhage arising from bleeding from the lentiform nucleus. Classic hypertensive hemorrhage. This one is a classic epidural hematoma with a lentiform shape hematoma outside of the brain parenchyma. So it's an extraocular hematoma with a classic lentiform shape. And the reason that it's lentiform is because the dura attaches to the suture. So the hematoma does not cross the suture line where it's tethered. And then this one is a lentiform shape. And this one is a classic subdural hematoma with a crescent shape along this left cerebral convexity, and it crosses the suture attachment because it's under or inner to the dura, so it doesn't get limited by the suture attachment. Classic subarachnoid hemorrhage in the basal cistern. Sometimes you can have subarachnoid hemorrhage in the cerebral cell side, but this one just happens to be in the basal cistern. So these are more obvious hematomas. Now, this one is less obvious, right? But you can still appreciate that. So this one has a little bit of subarachnoid hemorrhage right at the dependent portion of the cerebral cell side, right here. Now, this one has a little bit more up here. Sometimes you may just have one slide just look like this, right? So obviously, some bleeding with very, very mild subarachnoid hemorrhage. The hemorrhage can be very subtle and small. So when you look for subarachnoid hemorrhage, obviously you look at everything, but also pay attention to the dependent portion of the brain, or the cistern, or the CSF space. You can see that this one settles in the dependent portion of the Sylvian fissure. Look at the dependent portion of the ventricle, like right here. When you look at cisterns, look at the dependent portion of cisterns. Like for example, one of the classic location for hemorrhage is actually in the interpedicular cistern at the brainstem, right here. So you can have a tiny subarachnoid hemorrhage. So just in terms of general approach, we look for those areas, right? Because the clotted blood tends to settle down in the dependent portion of the CSF space.
Colin?
Yeah.
Very stupid question, but
Yeah.
these are all non-contrast?
These are non-contrast. Yeah. And sometimes, it's a good question because you may see, well, this is dense, and then this is dense too, right? And then what's this, right? So this is actually some of the, this is the false. Sometimes the false can give you misinterpretation because essentially the false can be a bit thickened, they can be calcified, and people can misinterpret hemorrhage along the forks with just normal variation. And here you have the septal sinus, right? And this is actually an important area to look, and I'll show you some examples, right? So these are kind of things that I hope as we go over, you'll pick up some points, okay?
Colin,
Yeah.
sorry, on previous slide, if you go to previous.
On previous one?
Yes.
Yeah.
Intracerebral hemorrhage versus tumor.
Yeah.
Other than knowing the history, what features help us to differentiate
The tumor?
tumor from intracerebral hemorrhage?
Yeah, sometimes difficult. Classic location will help, but this one you know that it's right center at the basal cisterns, the deep nuclei, right? So when you have hypertensive hemorrhage, you know that they often comes out of the deep nuclei. So the center right there, it's very unusual to have tumor center at the basal, at the nuclei itself, right? But sometimes when it's so bad, you just have no clue, okay? Sometimes you actually see a tumor, even without contrast. You see the mass there, right? And you can, that help you, right? Sometimes you just have no clue because you can have a small tumor and it just bleeds so much that it totally obscures it. In situations like this, unless you have a good clinical history, what we recommend is a follow-up after the hemorrhage is resolved. Follow-up with a contrast enhanced CT or MRI to make sure that we are not missing a occult tumor. So, just more example of subtle hemorrhage. This one is actually a recent case, and actually a good case because it's very complex. There's a lot of hemorrhage of different types. You can see that this patient has a subdural hemorrhage because it's a bit thickened, it's a bit question shaped, not as classic as the one I showed you earlier. But if you look carefully, you can see that it's a hemorrhage along the just adjacent to the scalp. But the patient also has some hemorrhage that actually goes in the cistern or the south side, right? So if you have hemorrhage that follows closely along the convexity, is probably subdural hemorrhage. But when it goes into the south side, you know that you have subarachnoid hemorrhage, and they can be both in the same patient. What I want to show you is, again, symmetrical flare, right? So this one, you can see that there's a little bit of massive fat. We look at cistern south side here. You can see the south side pretty well here. This one is a bit effaced, right? So you know that the ciliary vascular, not a lot, but just a little bit, right? And sometimes they actually can help you because it's useful to help you to pick up the difference. Also, remember subdural hemorrhage. Sometimes when they're small, they can be easily missed. Remember I mentioned that windowing is important, right? Look at the hemorrhage here. It's so close to the bone, right? So this is type of hematoma that you get subdural window. Basically a wider window so that you generate more differentiation between the bone and the subdural hemorrhage. Okay, so important to look at different windows. Same patient, and here you can see that there's a little bit more subarachnoid hemorrhage because it goes to the south side. But this patient also has some subdural hemorrhage tracking along the tentorium, along the forks. Also, this patient fell, and you realize that, let me show you another one. This patient has a hematoma here, right? So, because you have hemorrhage within the brain parenchyma with hypodensity considered with edema, this is a contusion. Now, you can also see that there's another one here, hypodensity, which can kind of look like infarct, right? But this actually happens to be a hematoma. Why I think that, obviously you can have a patient who has a stroke and then fell, and hematoma, right? But I think this is probably contusion. And the reason is that, here I'm just going to show you like a little bit more subarachnoid hemorrhage, right? Because there may be some subdural, but there's also a component of subarachnoid hemorrhage because it actually goes in the south side, as I mentioned. But the reason is that I actually can pick up a subtle non-displaced fracture, right? The fracture is right there. So the story I'm making up is that the patient fell, so cracked the skull with a contusion, and then a counter coup, contusion, right? So the coup and counter coup, right? And then with subarachnoid hemorrhage and subdural hemorrhage, right? So that's how you put the story together. So this patient has a lot of things, but you put it together, you can make up the story pretty well. And this skull fracture extends all the way down to the base of the skull. Now, one point I want to highlight is that non-displaced fractures sometimes can be easily missed. And especially if you think about, if you just look at one plane, and the plane happens to be a fracture horizontal to the axial plane, going through like this, you're going to miss the fracture, right? So sometimes look at the skull, the skull view, the one that they use to localize patient. Plane is kind of like a plane field. Sometimes you actually pick up fracture that you miss on the CT thin slicer by looking at the skull view, okay? So, all right. Again, just show the fracture at the base of the skull. No, you look at here, the skull is very busy. The skull base is so busy, there's a lot of lines, a lot of fissures, a lot of sutures. And sometimes you come in the case that you're not sure it's a fracture, is it just a suture? Again, symmetry is fracture. Look at the other side. Obviously, there's a little bit of like normal variation, but the symmetry help you to think one versus the other. At least increase your confidence. Okay. And again, just show you like why it's important to look at different plane, because here there's a subdural hemorrhage, check a lot of tentorium. When you look at one plane, if you're used to that, you can still pick it up. But when it's small, when you look at coronal planes, it's much easier because the subdural checking a lot of tentorium. When you look at the coronal plane, it's kind of like looking at the axial image, looking at this plane where the blood is checking a lot of convexity, right? So same idea. You just take advantage of the multiplanar capability of our current CT. Now, I'll show you the more obvious thing, right? So what's wrong with this one? Anyone see that? It's symmetry, good. So you know that this is a keeper, right? This patient is abnormal, right? No, it's more than that, right? So, we know that it's so asymmetric. Okay, which side is abnormal? Both? Definitely, right? Exactly, right? That's very good. Now, I'm showing this out. There's maybe some acute or maybe some acute because it's not as dense as the one that we saw earlier, right? So it's not hyperdense. But at least we know that there's subdural on both sides. And the problem is, one is so dark and one is isodense. Isodense or a little hyperdense. So the hemorrhage of different stages. This is a kid, right? So there's also hemorrhage. Actually, you can see that there's a hemorrhage because you can see a bit of sudden effect, right? So bilateral subdural hemorrhage, different ages, right? Now we need to call the children's aid, right? So it's important. The point I'm trying to make is not all hemorrhage is hyperdense. So you have to be aware of isodense and hypodense blood. This one is another patient with non-accidental injury with bilateral chronic subdural hemorrhage. And when you look at MRI, you can just see a lot of old brain contusion and other sequelae of brain injury because of the shaking. But at least on CT we know that this is bilateral subdural.
Colin, the last one.
Yeah.
How would just brain atrophy look different?
The brain, when you look at this, it's kind of like an old man, right? And the patient, because the patient has brain injury. So actually this patient has brain atrophy. Yeah. And if it's not atrophy, you won't see that. You see the ventricle is dilated. Obviously, patient can have dilated ventricles with chronic subarachnoid hemorrhage, right? Because it's causing problem with absorption of CSF. But this one patient also has chronic injury of the brain. And the patient also has a subdural, some brain atrophy as well. This is a misplaced slide I'm going to show you. Okay, this one you can again see that so hemorrhage can be a little isodense, right? So not all hemorrhage is hyperdense. So look for those. And this is actually a good one. You can actually see that this one is actually easy to pick up. Oh, thanks. But this actually another hemorrhage right here, right? And the way to look at it, when it's here, it's easy to pick up. When it's here, what you need to do, remember, look at the cortex of the brain, look at the great white junction. You can still pick it up even if it's like this. If you look at the cortex and great white junction all the way around it, you see that the great white matter of the cortex actually displaced from the skull, and there's something sitting there. Obviously, when you go high up, you can see that it's more obvious, right? See the brain get pushed up, but always look at the great white matter differentiation, and you will not miss any acute subdural hematoma, even regardless how small it is. Okay. So the pearls I'm trying to give is that hematoma is hyperdense only when blood is clotted. So beware of unclotted blood. Now, I showed you the subacute and chronic blood, but even acute blood, if it is before it's clotted, so when patient has coagulopathy, or when the blood is basically is actively bleeding on CT table, right? Before the blood can even the chance to clot, you will see hypodense blood. Obviously, you can also have hypodense blood mixed with hyperdense blood when you have acute or chronic, and so sometimes can be very confusing. Now, this is a patient who is a chronic alcoholic with coagulopathy, liver failure, has some coagulopathy. You can see that in acute hematoma, there's actually fruitful level because some of the blood is not clotted and some are clotted, right? So that's why the fluid or the blood fluid level, and partly because some of the blood get clotted and there's some cellular components which are heavier and settle down in the dependent portion of the hematoma. You can also see that if you look carefully and remember, look at the cell side, you can actually see the division of the subtle subaromatous chemistry right here, right? So right here, or right there. And also remember, look at the dependent portion of the cisterns. You can see that there's actually a little bit of blood within the ventricle, interventricular blood right here, right? So
how do you interpret that? How would you?
Oh, you
mentioned
know,
he's got subarachnoid as well as intracerebral blood.
yeah, exactly.
So how did he get the blood on the right side in the subarachnoid space?
You mean here?
There and that other
You mean here?
the other arrow, the open arrow?
The open arrow.
Yeah. How did he get blood over on that side?
Yeah, I can't remember exactly because these are some old cases that are contracted, right? So these are not cases from here. But you can see that this one actually is a big hematoma. So I think if I say, this patient can also have both as well, or maybe trauma, but you can see that the hematoma dissects into the ventricle, right? It's so big, right? So when you rupture, it's so big, and with the pressure, the blood actually dissects through the brain parenchyma, go into the ventricle, and because the CSF space complicates, right? So the blood can actually spill over into the to the CSF fossa.
So how did it get into the subarachnoid space anyway?
Well, it's because when you have the blood, the brain parenchyma, the parenchymal hematoma, they dissect through the brain. They actually go into the cistern. They go into the ventricle. This is subaromatous space, right? And then the blood can from there can travel to elsewhere. It's not uncommon that when you have a patient with big hematoma, you actually see the blood redistribute. So sometimes we use the term redistribution, right? Because they're not new blood, because the whole amount when you put all together, they count the same amount, but they're in different locations, right? And we don't consider those new hemorrhage. Okay, so what's wrong with this one? So this one has a heterogeneous hematoma, right? Sorry, epidural, that's right, lentiform, right? So good, all right. Now, it's heterogeneous, so that means that there's some blood which is not clotted yet, right? So when you look at, sometimes it's just because you haven't waited long enough, the blood, because they clot at different ages, but you have to be careful, right? Especially if they have this pattern, right? So you see that this kind of like a swirl sign. Remember, like when you squeeze the toothpaste and the things get ejected out, right? So this is actually a follow-up study for this patient. And this patient actually have this what they call the swirl sign. And what that means, right? It means that the patient is actually actively bleeding on the CT table, and that's why they they want to repeat the CT head, because the patient is a little bit unstable, and you let that just a few hours, 2 or 3 hours later, this is a hematoma, and when we scan it, the patient actually active bleeding. Okay, so something to think about. And sometimes, like, when you get back in a very short time. Now, sometimes there's some other diagnostic pitfalls, and one of the problem is calcifications. How do you differentiate calcification from tiny petechial hemorrhage, right? And this is an example that shows you some of the difficulty. This patient has a hemorrhage from the thalamus, so probably again hypertensive hemorrhage in the right thalamus. And this is no-brainer. I mean, we can't have calcification that big. But how about this at the left before nucleus, right? When we look at this one's a tough one. If we just have this image, we cannot tell. But fortunately, we have an old study, or maybe like this one actually have a follow-up. We know that this one resolved, and this one stayed the same. So this one tells to be calcification right here, and hematoma right here. If you have an old study, it will help you as well. When you have a new patient, look at the old study. It was there 2 weeks ago, right? It's going to be calcification. The other thing is that it's a common location. So the lentiform nucleus is actually a common location for calcification, right? So location help you. Again, just the same theme, calcifications misinterpreted as hemorrhage. And this one is actually was misinterpreted as hemorrhage. And so they recommended MRI, and then there's no hemorrhage, obviously, because this patient has tuberous sclerosis, and they have calcified tubers. So you can see that this one is actually more discrete. So this one you should not misinterpret that, because some of the features that have differential calcification, if they're available, is that they have very sharp margin, they have no edema around it, and they're in common location, like basal ganglia. Some are difficult, but this one is right at the epidermal surface, which is typical for subependymal tuberous in tuberous sclerosis, but some are more difficult, right? So just
Colin,
things you look for. Yeah.
if you go back that one slide,
Yeah.
these are the ones that we probably find so hard. We understand the concept of the symmetry, but sometimes the heads are a little cockeyed when they're in the scanner.
Mhm.
And when you look at this one, the anterior horns are not symmetrical. So if I saw that, I would be thinking, gosh, there is something going on there, because there is lack of symmetry.
Yeah.
Do you have any trick that you would tell us to say, okay, that you can compensate by X number of degrees if you know this or that,
Yeah.
and restore symmetry to that particular picture?
Yeah. Well, the point is that some patients are born with symmetry. It's a normal variant, and this is a problem, right? So, I mean, I throw symmetry because it is helpful, but nothing is foolproof. I mean, otherwise, like it'll be easy. This one you can see that actually the skull is asymmetric, but it's not because it's asymmetric positioning with the patient. It's actually asymmetric. The skull is just smaller. There's a little bit of like asymmetry of the shape of the skull, and the ventricle is actually symmetric. And actually, it's quite common to have some mild asymmetry of the ventricles in normal variant. You can actually, when you see CT enough, you can see that actually quite common. So, how to differentiate acute hydrocephalus from the other one, right? You look for periventricular hypodensity, which suggests edema and things like that. You look for other things, right? So you just isolate the asymmetry and then mild. Yeah, sometimes, and I don't see any other finding, I would just comment that may be a normal variant. Is that fair enough? Yeah.
What about using dependency for differentiating between calcification and
Dependency?
Yeah, like if it's a dependent, you see at the bottom of the ventricles.
Oh yeah, definitely. Those cannot be calcification. If they're in the free space, CSF space, there must be blood. Okay. Now the other thing is that I mentioned blood. Think about if you have some patient with meningitis, right? Very often you don't see anything on CT. Sometimes if you're lucky enough, they have some debris, germ, and they are proteinaceous material. Same thing. Blood, clotted blood is actually kind of like proteinaceous material, and you can see something in the dependent portion of the ventricle, right? That's ventriculitis, very bad. The patient will be really sick. But same thing, same idea, right? So anything in the CSF space, in the dependent portion, is abnormal. Yeah.
if you use different windows here and found that the bone window had the identical number of units to that particular calcification, can you make the differentiation that that is calcification versus blood?
Definitely. If you have very high density, like not even as high as bone, but maybe like 80 or something higher, right? Then this calcification, this clot blood won't go as high. The problem is that very often a lot of calcification, the fine calcification, and then you're in an area that you measure that, and the calcification is just like blood. So it can happen, right? So everything helps, right? So I mean, these are not perfect, but if you have calcification, if you can put it density, sometimes you don't use the region of interest, just use a point pixel. Look at the pixel, right? Look at the field, and because when you have calcification, they're heterogeneous. But I often just move the cursor around, and if there are some pixels that have real high density, like 100, right, then I know there's calcification, and that increases my confidence. Okay. So this one is difficult, right? But there's a classic, like typical location, no edema. You put a pixel right down there. The calcification is 100, right? Then okay, that's calcification, right? And then you're pretty comfortable with that. This patient had a post-traumatic contusion with subdural hemorrhage. You can see that actually the hemorrhage tracking along the tentorium right here is basically a blood tracking underneath the tentorium, and that's why it's kind of fan-shaped. You can see that this patient has a contusion right here, similar to the one that I showed you earlier with some edema. Now, this patient also has something different, and is that, remember, I think you asked me like, what's this, right? This is sagittal sinus, and then you have sagittal sinus that drains into transverse sinuses. And the transverse sinus is draining along here. And you can see that this patient have this, which I can account for blood, but there's something followed closely along the convexity, relatively well contained, adjacent to the convexity, and this patient actually happens to also have a dural venous thrombosis. So just another thing that you can look for is to look for the clotted vessels. So instead of just looking for clotted blood in the brain or outside the brain, look for clotted vessels. It works for stroke, because we talked about the dense MCA sign, which is clotted MCA. When you look for venous sinus thrombosis, you look for the dense venous sinuses or cerebral veins. Now this patient has hematoma right here. Not quite classic for hypertension, right? Because it's not basal ganglia, it's in the temporal lobe. So, anyone see anything else apart from this? Yeah, definitely there's an effacement, a lot of edema, right? Okay, so what are some of the causes for parenchymal hematoma? Spontaneous motor trauma, where it can be tumor, patient can have, older patient, it can be amyloid angiopathy, right? Can be tumor, can be coagulopathy, right? Things like that. The other thing is venous infarction, right? So the patient has cerebral venous thrombosis, and because of the clotted vein, the brain cannot have a good venous drainage, right? Increased pressure, that will trigger the hemorrhage, right? So this patient has a hemorrhagic infarction right here. Because when you look here, you can see that there's some density away from here. This happens to be where the sinus is, the transverse sinus. Now, obviously, we can prove that by doing CT venography. Okay, so you can see that here you have the normal enhanced sagittal sinus, right transverse sinus, sigmoid sinus, and on the left side is nothing, right? So it's clotted. When you need this venogram, you can do an MR venogram. I like CT venogram. A little bit more radiation, a high resolution, very easy to do, very easy to read, because you're basically just looking for filling defect, just like when you look at the PE study, right? So I find it very foolproof, very easy to read, and you can pick up a lot. This is another patient with hemorrhagic infarction. Right here, the patient has, some of these are sublunar hemorrhage. Some of these are actually, one of these is actually a clotted cerebral vein. So instead of a dural sinus, this patient have clotting or thrombosis of one of the superficial cerebral vein, causing venous infarction. Now, when we think about venous infarction, we think about venous infarction with brain parenchymal hemorrhage. One of the clinical presentation or the imaging presentation of venous thrombosis is actually sublunar hemorrhage. So one of the differential diagnoses for sublunar hemorrhage, spontaneous one, is actually venous infarction. So just something to think about. When you have a non-contrast enhanced CT, look for the asymmetry, right? So here you have asymmetric density of the sigmoid sinus right here, a bit dense. And it's basically iso or normal density on this side. So this is the non-enhanced CT clue of venous sinus thrombosis. It's an asymmetric density of the vessel. Same thing for acute stroke. When you look at the dense MCA sign, it's an asymmetric density of the vessel. When you give contrast, obviously just like the CT venography, right? We have a filling defect in the sinus, where you have normal filling on the other side. And this is called the LT delta sign. Okay, so this one is a bit different. So what do you guys think? I think this is the last case that I will show, because I think we're running out of time, but this one is so cool, so yeah.
Is it hazy?
Huh?
Is it hazy?
Hazy?
Yeah.
Very good, excellent, yeah. This is actually a case that, Huh?
Yeah.
Excellent, well, I mean, that's actually, you pick up the most important thing. Because, you know, this one is actually the one that I read with my resident when I was in university. And obviously, everyone pay attention to the dense stuff, you know, the hemorrhage and things like that. So people say, well, this is sublunar hemorrhage, right? So this is the report, the prelim report, sublunar hemorrhage. But they're missing the more important thing is that the whole brain is so hazy. Remember, do you see the gray white matter differentiation? It's gone. How about a cistern, the basal cistern? It's small, it's effaced, right? And what's going on? Right, this is a cardiac arrest. The whole brain is swollen, right? And that's actually more important, right? Sublunar hemorrhage is a little bit, who cares, right? You know, patients don't really die from it, but patients will die from acute edema. And what you're seeing here, density, is actually not blood. It's actually the dense vessel because of pressure in the increased pressure because of cerebral swelling. The blood slows down. It doesn't flow properly, right? If you look at that, you can actually see some of the vessel here, similar to that. So these are just vessels with slow flow, no hemorrhage. The patient has diffuse cerebral edema. Yeah. So another pitfall of sublunar hemorrhage or dense vessel is the vascular stasis when they slow down. And in this case, it's the brain edema that slow down the flow of the vessels, and also because of the brain edema is lower density, it accentuates the contrast of the vessel, make the vessel look more dense. So remember, look at the forest and the tree. Just look at, don't just focus on one single isolated finding or localized finding, but also walk back, look at the whole brain, look at the whole study. So this is a patient, same patient next day. You see that there's actually crowding of the foramen magnum as well. So this patient has basically transtentoric herniation, bilateral uncoherniation, cerebral tarsal herniation. So obviously this patient did not make it, right? So it's so unfortunate. But I just want to show you this one. Just, you know, I think it's important to pick up.
The cone?
Yeah.
So I was actually just going to ask you what's going to be on the right eye there.
The right eye?
Is that just bone?
You mean here?
No, it's on top.
You mean here?
Yellow, yeah.
Oh, this is a part of the spinal.
Okay.
Yeah, we just partial water in here. So, yeah. Now, sometimes when you have localized edema, remember symmetry, right? So some symmetry is not always perfect, but you may have just localized effacement of the cell side. This one is diffuse effacement of the cell side, sometimes just localized. Okay, so sometimes those effacement of cell side can help you to pick up subtle mass effect. Okay, so just bilateral coordination. Same patient, I just want to show sometimes the other plans help you to appreciate the findings. Or remember, this is a basal system. Because of ancoherenation, this space got effaced, is gone. The foramen magnum, because of cerebral consolidation, this space is gone, right? So. Okay, so remember to look at the system for asymmetric effacement. And look at the foramen magnum. Okay. Now I think the time is up, so maybe I should stop there.
Thank you very much, Colin. That was great. Can I ask just one process question? So in the middle of the night, and you have an obvious finding that needs neurosurgical intervention, can the X-ray text upload the ENITs? So that process then, from an emerge doc perspective, you just go ahead and call, and there's no need to call the radiologist then when it's very obvious? Yeah, okay.